Gluten gets talked about like it is one switch. Eat bread, feel bad, blame gluten. But the packet keeps separating autoimmune disease, allergy, fermentable carbohydrates, and self-reported sensitivity. So what is the cleanest first split for someone trying to understand their symptoms?
Start with the molecule, not the marketing. Gluten is a family of storage proteins in wheat, with related prolamins in barley and rye. In most people, those proteins are just digested imperfectly and move on. In genetically susceptible people with celiac disease, fragments can trigger an immune process that damages the small intestine lining. The highest confidence benefit of avoiding gluten is for confirmed celiac disease. There, a gluten-free diet is not a wellness experiment. It is the only established effective treatment in the packet. The target is not just less bloating. It is mucosal healing, fewer malabsorption problems, better nutrient status, and lower ongoing immune injury.
If symptoms overlap that much, can a person use a home trial as proof? Like, if I stop wheat and my stomach improves, does that tell me gluten was the culprit? Or could I have changed several things at once?
Exactly. Wheat foods carry gluten, but they also carry fermentable carbohydrates, especially fructan-type fibers. Those can reach the colon, feed bacteria, and generate gas and fluid shifts in sensitive people. That mechanism can create bloating, pain, and irregular stools without autoimmune villus damage and without an allergy reaction.
Where does wheat allergy fit then? People sometimes bundle it with celiac, but allergy sounds faster and more like hives, swelling, wheeze, or emergency symptoms than slow intestinal injury. Is that a fair distinction?
That distinction is why I would not start with a permanent gluten-free diet before discussing testing if celiac is plausible. Removing gluten can make celiac blood tests and biopsies harder to interpret. So red flags, chronic diarrhea, weight loss, iron deficiency, family history, poor growth, or unexplained nutrient deficiencies deserve clinician-guided evaluation while gluten exposure is still present.
Suppose someone already has confirmed celiac disease and starts the diet correctly. What should count as helping? Feeling better, better labs, biopsy healing, fewer deficiencies, quality of life? I'm trying to avoid making the scale just whether today's stomach feels calm.
That is the right frame. Symptoms are valuable, but celiac management often tracks objective evidence too, because some people feel okay while inflammation or malabsorption persists. The packet also notes that people on a gluten-free diet can still have nutrient imbalances and reduced quality of life, so the diet needs follow-up, not just a label on the pantry. And gluten-free does not automatically mean nutrient-dense. Many products rely on refined starches. The amaranth pasta review is useful because it shows the trade-off. Adding about 10 to 25% amaranth can improve protein quality, minerals, fiber, and antioxidants, but it can also hurt texture, firmness, cooking loss, and sensory acceptance unless processing is optimized.
The prebiotic review mentions oats, quinoa, and amaranth in people with celiac disease. Is the practical message that a gluten-free diet should become more diverse, not just swap wheat bread for pale starch versions of the same foods?
Yes, with evidence humility. In the celiac prebiotic review, oats at 50 to 70 grams daily for up to 24 months maintained histologic remission and negative serology in included studies, while improving iron, fiber, thiamine, and zinc intake. Inulin-type prebiotics increase short-chain fatty acids and bifidobacterium, but these are adjunct signals, not permission to eat gluten. For confirmed celiac disease, the boring details are medical details, labels, cross-contact, shared fryers, bulk bins, and restaurant uncertainty. Also, oats are not automatically safe. They need to be uncontaminated and tolerated individually. Anyone with wheat allergy has a different safety plan, because accidental exposure can mean allergic reactions rather than delayed intestinal inflammation.
There is also a pilot study combining a probiotic with plant sterols in adults with celiac disease and high cholesterol. How should a viewer hear that without turning a small study into a shopping list?
Hear it as a signal. In 9 weeks, the active group had reductions in total cholesterol, LDL cholesterol, non-HDL cholesterol, and apolipoprotein B, plus shifts toward greater microbiota diversity and more bifidobacterium. But the population was specific: adults with celiac disease and hypercholesterolemia. It supports further trials, not a universal celiac supplement rule. The final caution is not to make gluten the answer to every severe gut problem. The collagenous sprue review describes rare but serious enteropathy with diarrhea, malnutrition, low albumin, electrolyte problems, medication associations, relapse, and substantial mortality in reported cases. Persistent weight loss, edema, dehydration, anemia, or severe diarrhea needs medical workup, not another elimination experiment.
So the decision is not pro-gluten or anti-gluten. It is rule out celiac before hiding the evidence. Separate allergy from gut fermentation. Use symptom trials carefully. And if gluten-free is medically needed, make the diet nutrient-dense enough to live on. Is that the fairest compression?